All right. Welcome to our July ED provider meeting, and welcome to Microsoft Teams. Hopefully this will work, and hopefully we'll be able to actually get this recording to people. That's why we switched back to WebEx before, because it won't let me send the link to non-Mercy Health email addresses, but I've requested like a special allowance for me to do it. We'll see if it works. If not, I have some other tricks up my sleeve. So let's start with a reflection. This is by Douglas Cox. This day is mine. Today I will search for the goodness in everyone I meet. I will remember that light reflects off the whole world around me, and that how I view that would depend on the glasses I choose to wear. Today I will walk through doors and lives, knowing that it is my contributions, not my comments, that shape the world around me. It is not the big things, but the little things for which I will best be remembered. In any case, I will be myself. I will feed where there is hunger. I will comfort where there is loneliness. I will listen to the words, the music, and the rhythm of those with whom I share my life. I will bring love where there is hatred, fight for what is right, make amends for any wrongs I may have done, and ask forgiveness for those I have harmed. Today, I will hug my loved ones. This day is mine to work for the Harvest Master. All right. Just briefly, we didn't go over any metrics last time. I'll briefly run through these, and you can take a closer look on your own as you're reviewing these. These are our metrics with the blue left without being seen at the bottom. The numbers have been fairly stable for the last few months or so. You can see the breakdown, the average census by month. So we hit kind of a low in February of 141. But for the last 3 months, we've been between 159 and 163 with a slow raise. Ending last month, we did manage to round down to 3% left without being seen, which is great. Excellent job, especially with slowly rising volume. That's wonderful as we continue to work to reduce those. Throughput time, and again, comparing to the previous months, you can see that some of our numbers have been fairly stable or a little bit longer, like the arrival to depart. Bed assigned to admit time is stable, just over an hour. A lot of these numbers have continued to remain stable for the last several months, but significantly better when we were at the peak of our surge. Arrival to provider time is 19 minutes. Pre-COVID, we were down around 16, 17 minutes, but in our surges, we were up over 30 minutes. So this is good. That's it for the metrics. Oh, my head is in the way. Wow. Maybe I should get over a little farther. All right, so keeping with the theme of trying to keep most things clinically relevant and things that are easier to kind of demonstrate live, I'm leaving a lot of the logistics up to the emails, but there's one thing that has been kind of simmering below the surface that I wanted to bring up, and that's talking about med history and med reconciliation. As most of us are aware, the med history doesn't always happen as well downtown as it does at Southwest. I think we all appreciate that the nurses do a much better job of completing a med history at Southwest than they do downtown. This is something I've been talking with nurse leadership about for years downtown, and we've made various pushes. It's been hard for them to really focus on this because of staffing issues and kind of burnout and just other priorities. But I'm in the process of initiating requests for this to become a higher priority downtown. The med history should be part of the nurse standard work in the triage process. It's also best practice per ACEP and CMS and others that we as the providers do med reconciliation on all ED patients. Now we know that this can be challenging and is time consuming and sometimes is more relevant than others. You know, when we're prescribing new medications, when we're prescribing anything in the emergency department, it's useful. It's obviously important if we're providing medications like Paxlovid. It's super important for any sort of overdose or toxicology case or psych patients in general, trying to figure out when their last dose of their long-acting med is, and multiple other reasons why it's important. So if you haven't done much with the med history and the med reconciliation, this is your EPIC training day, briefly. So I'm just going to point out a few things. We might even jump to EPIC here in a second. But in the triage tab, there's a section called home medications. And when you look at this, these different icons mean different things, and you can hover over them and they'll tell you what that icon means. So for instance, when you see the house, you know that that is a medication that's been prescribed through EPIC, through our system as an outpatient medication, such as through their primary care physician. When you see the person with the little talking bubble, that means it's patient reported. So typically a nurse would have put that in after asking the patient, what medicines do you take, and the patient telling them. The thumbtack means it's a long-term medication, so it's not, that's like a message to other providers that you don't want anyone to remove that medication. And then the little piece of paper with the corner turned down, if you click on that, it can give you more details about that medication, including when the last time it was filled, if that information is available from the pharmacy. So there's, you know, a lot of information you can get just from looking at this directly. There's two ways to modify this. And the best way is when you see this link that says new medications from outside sources are available for reconciliation. You can also click on that little pencil there next to home medications. But I'm just going to show you what this is like. So if you haven't, let's say the nurse hasn't completed the med history, or even if they have, if this appears there, you can use this to update the med list and make it more accurate and to figure out what they're really on if the patient doesn't know, which we all know is relatively common. So here's the second way, is clicking the pencil. So if you click the pencil, for instance, it takes you to the medication home screen. And from here, you can see, I think I can, let me figure out how to get, oh, I don't know how to get the little pencil thing. But right here, it says new home medication, there's an add button. So you can just type in, you know, Coreg or whatever, and you can bring it up and you can add it there. We are capable of doing this completely by ourselves without any nursing help if necessary, but preferably this is done by nursing. It would be quite important to add certain medications, even if nursing can't do it, if they're relevant to the clinical situation. Like for instance, adding that a stroke patient is on Xarelto as a reason for not giving them TPA or something like that. So the other option is this go to reconcile. So let's click on that. If you click on that, you get to this med reconciliation page, and this is really the page that you want to look at closely. When you get to this, all these little E, these epic E's that you see for like the Care Everywhere, those are really important. When you see like the person with the bubble or the house, those are the medicines that appear on that med home list that you see in triage. All of the other medications that have the epic E, Care Everywhere, they don't appear there. They're waiting for you to reconcile them. So all you have to do to make them appear on that home screen is just push the plus button. If they're not supposed to be there, you can push the trash button. So it's pretty easy to add these. The best and easiest way to do this is actually to use the computer in the patient's room. So you can sit there and just go down the list. Are you still taking prazoline 15 milligrams? No. Are you still taking the Abilify Maintina long-acting drug? Yes. You know, trash can plus. Are you still taking trazodone? Yes. Hit the plus. The only part of this that's a little bit tricky is if you're going to trash a medicine or if you're going to add a medicine, you want to make sure it's not a duplicate. So you might have several different prescriptions, let's say for trazodone, because they were prescribed by different prescribers. And so you might need to trash two of them and add the last one. Or if there's a trazodone here with an E and there's also a trazodone already on their Epic, you just need to verify it's the right dosage and the right frequency and then trash the wrong one so you don't end up with multiple of the same medications on the home screen. That's basically what med reconciliation does. I also mentioned this specific example shows you this Abilify long-acting Maintina. You know, these medications we have struggled with. You know, 100% of the time you need to verify when the last dose of this was given if you're planning on giving a long-acting intramuscular, you know, psychiatric medication in the emergency department. And this is a good way of figuring out when the last time it was dispensed. So this brings me to another feature that I've been talking with the ED pharmacists, and a lot of ED providers don't seem to know about this feature at all, which was the main reason I wanted to go over this, is there is a pharmacy dispense report. And although you can dig into the details of these medications, like you can click on this the medication itself, and you can see some of the details. The pharmacy dispense report gives you just a list of what was actually dispensed. And this is super useful because you could have a list of medications that were prescribed, but this is how you can figure out whether they're actually filling it and taking it. And you might also discover, you know, that something was recently prescribed that might not even be on the list. So here's how you get to this. The same way through the home medications, go to that new medications from outside sources. So here you're back on this med reconciliation screen, and then in the upper right, there's in blue text here a link that says dispense report. So if you click on that, you're going to see just a list of medications with no details, and you can click on each medication, or you can to expand it, or you can click expand all. So in this case, there's the benztropine, the clozapine, but I clicked to expand the aprazazole, and you can see that this is showing short-acting Abilify at 5 milligram tablets, short-acting Abilify at 15 milligram tablets, and then you also see the long-acting intramuscular 400 milligram, and you can see there that the most recent this was dispensed was on 5/31. It says it's a 30-day supply, but the quantity is 1. because it's a single injection and you can see who prescribed it. You can also click on further details if you click on that blue text at the end, and you can see which pharmacy it was prescribed from, how it was prescribed, and who the provider is. So this can give you, like maybe you need to contact that provider in this case, or just, see where it was prescribed from. I mentioned this also because, we did have a recent case where, somebody came in with a overdose that appeared well and did not disclose what they had taken. And they were sitting there waiting for their kind of 6-hour get better medical rule out. And then they went into status epilepticus and cardiac arrest. And it was only then, after the pharmacist went through the dispense report, that they discovered that the patient had been prescribed 90 Wellbutrin XL tablets like 10 days before. So it does have clinical relevance, and the information that Epic pulls in from not just our system and not even just other Epic systems, but from pharmacies all over the state is really powerful. So I just want people to be aware of the dispense report and all of the tools that help you to figure out what medications the patient is on. And I wanted to let you know that we will be working closely with nursing to do a much better job of making sure that nursing are completing the med history. Ideally, what should be happening is that med history should be completed, and then we just simply review it, or if there's conflicting medications, review that in the reconciliation section. Are there any questions, comments, feedback on med reconciliation, or other tips that other providers have for this? All right. It seems like this pops up as a recurring item. Insulin infusions, yet again. I don't mean to just hammer this, but it keeps changing a little bit. And so I apologize for that, but I want to go over insulin infusions one more time, because even since the last meeting, the order has changed yet again. So recall, I think it was the last meeting, that the name of the order changed. It used to be insulin infusion and hypoglycemia treatment, SMGR only. And now it changed to insulin infusion and hypoglycemia treatment, glucose management software only. So that's how you get to just the insulin order. The embedded order is the same whether you go to the emergency medicine DKA order set, or if you use this order, it's the same embedded order. But what they did is they removed the default infusion rate. So you may recall that the typical default infusion without a bolus is 0.14 units per kilogram per hour. That's gone now, so you have to remember that. Another alternative is the 0.1 units per kilogram per hour with a bolus, but that's typically not what's recommended in the emergency department, because we're giving so much fluid. We run the risk of precipitously lowering the glucose level if we give a bolus plus 2 or 3 liters of fluid, which is often what we're doing. So anyway, that changed, and it now says in this advisory, must enter ranged dose. It didn't used to say that before. So this is causing some confusion to providers and to nurses, because the range is really specified by the glucose stabilizer software. right? But I think they added this because they wanted yet another check and balance for safety. If, you know, if for some reason the software gives you some crazy range or such. So providers have been asked by nurses to put in a range, or they're trying to figure out how to do this, or they're confused because the software is supposed to do this. So here's what we did. Typically, you're not going to go over 20 units per hour. And again, this is units per hour, not, you know, units per kilogram per hour. The only reason you would go over 20 is if you had, you know, someone who was like 200 kilograms. Then, you know, then you might be up in that range. But you're probably going to want to be aware of that. And, you know, you may want to start slower than that anyway. So, you know, 20 is not a hard and fast number, but I just kind of made that up as a typical upper limit. And so what I'm going to ask the providers to do again, you know, hopefully everyone is using the dot glucose stabilizer smart phrase. Whenever you do this in the admin instructions, I want you to erase all the text that's in there and just type dot glucose stabilizer or dot gluco. It'll pop up. Use the glucose stabilizer, then hit F2 and click either DKA or HHS. And then you should be good. And what we've done is I've modified this smart phrase to now include at the bottom here, you can see it says dosing rate range 0 to 20 units per hour, notify provider if rate requested by software exceeds 20 units per hour. So hopefully this will take care of the issue, but I wanted you guys to just be aware of this. If you have someone who's 500 pounds, you might want to change this so that it doesn't cause confusion with nursing if the software bumps it up to 25 units an hour or something like that. And I just wanted to reiterate, you know, please use this. You know, this is one of the keys to this is it says start at 0.14 units per kilogram per hour for 1 hour. If by chance you chose a different, perhaps a lower rate, you would need to specify that in the order, and you should also change this here as well so that they align. It has the word no bolus here, which is critical because the glucose stabilizer software, if they don't choose the right option, will tell them to use a bolus. So this is kind of an important safety tip for this. And then it also has the potassium disclaimer here, but hopefully you've gotten the potassium back before you're ordering an insulin drip anyway. All right, any questions on this? All right, Tom, you are up. Tom is going to give us an update on some imaging tips that some gracious tips that we've gotten from our radiology friends. And he's also going to give us an update on some MEDIC information. MEDIC, as you know, is our collaborative quality improvement commitment with other hospitals across Michigan, and we do get some, you know, financial feedback for our quality work that we do in that arena. So, Tom, go ahead and take it away.
Great. Can you hide your body or move it to the side a little bit? Because it might cover some very important.
Now you're asking for a lot. Let me do this, and then this.
Yeah,
is that good?
Yes.
All right.
So yeah, as Dan mentioned, this is going to cover two general subjects. One being MEDIC and our metrics that we're following through MEDIC, and then the other being the meetings that we have with our radiology department and some of their thoughts. The overlying message from both of those entities is kind of that everyone wants us to do less tests. So despite my best efforts, a lot of sarcasm did end up getting into this presentation. And we'll see how it goes. So first up, we did talk previously about our head injury patients, about applying the Canadian head CT rules, which is one of our metrics that we're following. So in the last 3 months, actually, we have done extremely well on this. So we had the metric measure that we were initially following. We were at 57% quote appropriate CTs according to applying the head CT rules. And then in the last 3 months, we've increased that to 71% of what they would consider appropriate, which is actually pretty amazing. So the people that are tracking this data were actually pretty impressed with how we've improved in the last 3 months. So good job for all of those that are using those Canadian head CT rules and holding off on some of the CTs when appropriate. I just wanted to now kind of go over a couple of cases, and I review all of these that are considered fallouts that we maybe could have applied the rules and we didn't, or maybe didn't quite apply them exactly correctly. So I just wanted to highlight, we do tend to do some CTs sometimes when a patient describes they lost consciousness. And when you look at the Canadian head CT rules, loss of consciousness, and if you have amnesia to the event itself, people say, I don't remember what happened in that car accident at all, or if they were witnessed to be disoriented at the scene. All those are where you would kind of use your pretest to then apply the Canadian head CT rules. They're not actually a part of the rules themselves. They're the first step where you would, those are the symptoms, and now I'm going to go down the head CT rule pathway. I listed the rules there. Go back. Yeah, I listed the rules here. You can review them. I usually go to MD Calc to do it myself. And one point about the mechanism, that's something that we get a little bit hung up on. The mechanism part of the head CT rules, as far as a dangerous mechanism, only includes if you're a pedestrian struck by a motor vehicle, if you're ejected from a motor vehicle, or if you fall from a height of over 3 feet or down greater than 5 stairs. There's no other dangerous mechanism that they would consider, just those. And then the vomiting is more than one. So you get to have one episode of vomiting and you're still good, but more than that, and then we need to consider head CT. So here's some cases that from us, I did mix and match a little bit, so no one's going to see their necessarily specific case on. Well, maybe, but everyone had similar cases. So the first one that we see quite a bit is our intoxicated patient that fell, and they have laceration on their face, and they're probably in the hallway, and their speech is slurred. They're typical, responding fine, but intoxicated. And then we got to ask ourselves, are we going to CT this patient, which a lot of us would. We can't really clear them right now because they're altered. The sticking point from medic is that if the patient has a GCS listed of 15 and we do the head CT, then that's one we're going to get dinged on. And a lot of times we don't put the GCS in, but it is a part of nursing triage. And just like a respiratory rate of 16 that they put in, they a lot of times will put in a GCS of 15, even if that's not the case. So we're working with them to make sure that we get an appropriate GCS on these alcohol patients. Go ahead. But we can put our own in also, and that's what I've started to do. So if you're hammered in the hallway, your GCS is not going to be 15. You can even best verbal response, you lose a point for that if you're confused. All these people are confused. So initially, if you're going to get that head CT on these alcohol patients, which a lot of times we do, maybe just add GCS of 14 into your neuro exam, and then we're good. Another one we get dinged on a little bit is the mechanism. So there was a case where somebody was hit in the back of the head with a metal baseball bat, which sounds like a dangerous mechanism, but no, that's not dangerous at all. That's a reassuring mechanism because it's not in the Canadian head CT rules. So anyway, if you're gonna apply the rules, the dangerous mechanisms are the ones we talk about with the flying out of a vehicle and going through a winch or falling down a greater than a height of 3 feet or 5 steps. Those are the only ones that you can use from a mechanism standpoint. So yes, at times if someone gets hit in the back of the head with a metal baseball bat and they have some associated symptoms, maybe they pass the Canadian head CT rules, but maybe you're still concerned and you're going to get the head CT. That's fine. Again, we're just trying to do our best. But if you're truly going down the rules, then this evidence-based that their risk of having a intracranial hemorrhage is exceedingly low. Even with because you're going down all the other criteria, which are reassuring. So there's another case we had here, which is kind of interesting actually. This patient got hit in the head, did have a loss of consciousness. So that kind of puts us down the pathway. No other real associated symptoms. We did get the CT, and this ended up being a false positive where they had to stay in the ER for 6 hours and get a repeat CT. So if we had followed the path, maybe we could have saved ourselves 6 hours of headache. But again, that was kind of that loss of consciousness was the main concern. That kind of gets us down the pathway in the first step. Not necessarily a direct indication for a head CT. Switching gears from a head injury standpoint, the other new medic for us step that we're going to be following, we stopped doing the PE metric as it was just ridiculous and confusing, and felt that this would be a little bit more straightforward. So the medic recommendation is basically pediatrics in asthma, croup, or bronchiolitis. They don't want us to do chest x-rays, essentially. So the more chest x-rays we do in this population, the less we are passing the metric and less we're getting this reimbursement. That's the general thoughts, and we'll go over that in a little more specifics here. So this is kind of an overview that I didn't make at all. I had nothing to do with this because this kind of games the system a little bit. This comes directly from Dan Roper. I had absolutely nothing to do with this slide. But in general, if your final seriousness to start with, the metric that what we want to focus on is if you have routine asthma, routine croup, routine bronchiolitis, we should probably not be doing x-rays on those patient populations, and that's evidence-based, literature supported. So that kind of puts us down the left side of the pathway there, where if your final diagnosis are those routine, we probably shouldn't be doing an x-ray on that. That makes sense. That's not what the measure is, though. The measure is, in general, all the patients, even if they have high-risk features, they still will ding you if you do a chest x-ray, which to me, I don't think we can enforce ourselves on that to be if someone has a lot of high risk features, we're going to just hold off on an x-ray. That's not fully evidence based, but I think we have some room to go with this on the routine asthma, croup, and bronchiolitis. You can see this pathway here. If you get down to the left side here and the patient's diagnosis, let's say, for example, is asthma, but they have high risk features. They've never had asthma before. They're hypoxic. You're going to admit them. And you're like, boy, I really think I should do an x-ray. You can go back up to the top and maybe your diagnosis, this is what Dr. Roper would say. Maybe the diagnosis wouldn't be asthma. Maybe it's URI. And then you can just x-ray it up as much as you want. No problem, falls out of the metric. No, that's the sarcastic point of view. But in general, routine stuff, we're going to try to hold off on x-rays as best we can. So here's some examples that we had from our facility. And this was a 10-month-old barky cough, had some stridor. And there's an x-ray done to kind of rule out foreign body. Could this be that causing stridor? Not unreasonable. They're not necessarily a history of foreign body there, but sometimes we'll do that if we're not sure. So are we good here? Let's go to the next slide. No, that's a horrible fail. We lose points. We should never be doing that. But in general, if you're going to need to do an x-ray, that's fine. Again, we're just trying to do our best. But that would be kind of considered a routine croup, or maybe we give some medicine, see how they do, and reevaluate at that point. Next one was a kind of a cough, URI, some wheezing. Again, we did an x-ray here. And final diagnosis of bronchiolitis. And from a medic point of view, they would say we just horribly failed. Go next one, Dan. But again, in general, no one's going to be upset if we feel uncomfortable and we do a chest x-ray in these situations. Last one here. See, this is an example where I think all of us would pretty much do a chest x-ray. Patient comes in severe distress with wheezing, no formal diagnosis of asthma, was hypoxic, and the final diagnosis was asthma because it was very consistent with that. There was family members with similar history. So the medic would say that this also, even though this has several high-risk features, they would also say this was a fail. We shouldn't be doing chest x-rays in this patient. But I think in general, this is where we're not going to be, we're not looking for 100%. We're just looking to kind of, off the top, the routine ones, try to do our best with those. I'll go to the next one here. So in summary, routine croup, asthma, bronchiolitis, I think that we have some room to go. We don't see a lot of pediatrics in general, so our numbers tend to swing significantly depending on the month and how many peds, croup, asthma, and bronchiolitis we even see and what season it is. So if we can focus on the routine ones and not do chest x-rays, I think we're doing a great job. And we already actually see, even though we didn't even bring this up, we've already had improvement in the last 6 months on this. So we're already somehow doing better than we were in the past. So we'll just keep it up. So this moves on to our next topic, which is we meet with radiology every yeah.
Before you get to that, just on the Canadian HET CT rule, there are some exclusions with that, right? The age and the anticoagulation.
Yeah,
just
if you're anticoagulated, yeah, you're automatically excluded. Age is a part of the algorithm itself, so if you go through it, you'll see that on there. But if you're over 65, then that will exclude the patient, and so you will all over 65s. You're going to be getting, they have a head CT ordered that passes, and those are on there as well.
Right, and just remember to document that. I mean, you could hit your head on a pillow if you're over 65, and as far as the rule is concerned, you'd be justified in doing a CAT scan. And also, don't forget that aspirin is considered an anticoagulant. If they've taken a single aspirin in the last 7 days, if you mention that in their note, then they can get a CAT scan if you feel it's clinically appropriate.
That's right. Even if you don't mention these things, some of those that are very easy to pick up from the chart, like it's very obvious if a person's 70 years old, the data reviewers pick that up without a problem. So even if you don't say, I specifically ordered a CAT scan on this patient because they're over 65. I knew they were excluded. They can pick that up. They can pick up if they're on aspirin. The ones we tend to get, hit for is the ones like the GCS is documented as 15, even though we said they're intoxicated and they're altered. There's no documentation of the GCS, so then they go by a nurse one, or and then that's where we get into trouble. So yes, those other ones are definitely exclusions, but the things that are very easy to pick up from a chart review are usually okay, because the coders are working with us. They want to try to pick up on as many of these as possible, so we do well. So we meet with radiology every, it's usually quarterly, and the last couple of quarters, there appeared to be some themes that they reiterated to us a few times that I know I've been mentioning to people if I work with someone. And yeah, they're kind of like pet peeves of radiology, but these are some of them that I thought were reasonable, that they're patterns that maybe we can improve on, that I thought it'd be helpful to talk about here. So there's a few of them. One is when we order a whole body pan scan, essentially for trauma. The next would be a CT max face. We'll talk about that more. CT of the T and L spine was a practice pattern that they were bringing up. And if the indication based on the EPIC default indications are not specific or helpful to them. And we'll go through these real quick. So the cases that I've been sent, and I asked them to send me the cases that they felt that they were concerned about, instead of after the scan was done, they call someone that's working on a shift and try to talk it over. I don't think that ever is helpful, and it just makes us mad when we're trying to work. So I've asked them to send me the cases that they had a concern. I can take a look at them. And so typically all the cases that I review are just totally appropriate. They're indicated, and everybody would do the same if they were in that same position. I think the trouble that we get into sometimes from their perspective is, if we order a scan of a pan scan of someone after a fall, there's usually a reason for that, but the reason doesn't always come across. So we might say pain, trauma, that might be the default EPIC, and if we don't free text in anything else, the text will add information. From a billing perspective, the radiologist, they need additional information on the reason for the study. And if the text puts something in that doesn't quite fit with the reason that we ordered, then it could come across as, well, why the heck are they ordering this pan scan for this person that has, this minor symptom or something? So I think we can help that by free texting in or dragging in additional information. And I know a lot of you already, I never did that, but a lot of people already do that, which I think is a great idea. And that's kind of the common theme among all of these. Oh, also, if a specialist puts requests, that's the other thing I wanted to mention. If, let's say, trauma requests a pan scan and you're putting the order in and it seems kind of minor or something like that, if you put in per trauma, that also kind of leaves us off the hook. One area that they felt maybe we were overutilizing was the CT max face in the setting where we order this kind of triple CT head, CT C-spine, and the CT max face. They sometimes will see the max face come across, and they're not seeing any soft tissue injuries or swelling, and they're kind of wondering, well, why did we get this full evaluation when there's really no signs of trauma? Now, there may have been and usually as I review them, there is a very good reason we've ordered those three things. And it doesn't, again, always come across in the reason. It might say pain, trauma. It doesn't say if there's ecchymosis around their whole face or they can't move their eye or something along those lines. So if you have a second to dragging that in, I think that really helps. The other thing is, I don't know if you have a trauma patient in the trauma bay, that's one thing. But if you have someone that got punched in the face, or I think we've got to think about, do we need all three of those studies, or can we use some of our decision rules to avoid doing one of the three, but in general, the cases I've reviewed are very appropriate. It just doesn't always come across in the reason. This one here, I know I've talked, they also recommend that the first line imaging for the lumbar and thoracic spine is plain films. They do not recommend jumping to CTs of the lumbar or thoracic spine. CT neck for sure, C-spine yes, but lumbar thoracic no. Sometimes we'll get a recommendation from neurosurge. We want that CT scan of the lumbar spine or something. If that's the case, again, if you put that in the reason, that really helps. If you have another particular reason where you want to go directly to the lumbar thoracic imaging from a CT perspective, free text that in there. But from their perspective, they get a lot of information from these plain films in the lumbar or thoracic, and are recommending we do that first. And if there's a concern after that, they would typically put that in their report. Or if you had an ongoing concern, you could then proceed with a CT scan and then free text in the reason for that. That's their recommendation. And then the last one kind of summarizes what we were talking about before. They don't know why the study was ordered. And I think, again, this is partly because the techs are gonna put in additional information, and they're getting that from what the patient maybe tell them or what they see from the chart. And if they put it in a little different, and I reviewed a couple of these cases, it's like, well, that's not really what the patient was saying. And it gets to the radiologist, and that's what they read. Any questions about any of those radiology topics? So,
Tom.
Oh yeah, go ahead.
Hey, it's Nick. I guess my only disagreement is about the CTs of the T&L spine. I think that sensitivity for those is 70% or so. And so if you have an older person, the osteoporosis, osteopenia, you would never be comfortable if you're concerned enough to get imaging to potentially miss 30%. And so basically what you're set up is that if it's negative, you're getting a CT, and if it's positive, you're getting a CT. And
yeah,
so that's why. Yeah, I think
that was not their message at all. They were describing that the CT, and I can follow up with them on that, and that's just a bit concerned because basically they're fractures or any kind of fracture, or
what's that?
Are you talking about just fractures in general, missing fractures, or just missing?
Yeah,
I'll follow up with them on that because that was not their take.
I think the general message should be we probably should image the spine less. If we're not worried about occult fractures or minor fractures, then we probably just should skip imaging altogether. But for those that were actually concerned, we're probably not going to stop with a negative X-ray, or at least I wouldn't for an elderly person. And typically it's elderly people that would be imaging. But anyways, I'll try to find papers as well. But my recollection is that sensitivity was not great. Point.
Yeah, they definitely, their message was that sensitivity is not great on the C-spine, but T&L, they did not have that message. So I'll have to follow up with them too, because I haven't done, I kind of went with their recommendation on that. So I'll have to see what the actual literature says. So that's a good question, and I'll follow up on it.
Yeah, and just to add to that, they did mention, plain film as first line.
Right.
So, perhaps they are asking for 2 studies rather than, as you mentioned, Nick, it's, the first one is kind of unnecessary if you feel like you're going to be getting the CT, even if it's negative. But it's such a small amount of radiation. I think they're looking to screen for that. If it's positive in some weird, bizarro world, they think maybe you wouldn't need a CAT scan to further delineate the compression fracture. Knows.
Well, there's a case like last week we had that neurosurge. We had a CT of, I think it was the admin. I can't remember who had this case with. And then it showed a compression fracture, and then they wanted on the CT, because it's for the admin, then they want us to get plain films to better evaluate. Like what? So I don't know if everyone's on the same page here, but I think we're a pretty evidence-based group. So I think that'd be great if they could send us some evidence showing we can be confident with our TNL spine plain films to be done with it. If that's their position, then it would be nice to get some evidence for that. So I'll follow up with them on that.
I think they did also mention like ordering CTs of this L spine for radiculopathy when really, you know, what you really need is an outpatient MRI. Because that was the other concern, is like non-traumatic L spines and those kinds of issues is something we really should think about, since technically it's the MRI that is the definitive test for that.
So yeah, nothing really further here. This is kind of a summary. We're actually doing really well on these medic. Even though we didn't even bring up the pediatric one yet, we're doing pretty amazing on these head CT rules and even the chest X-ray. So keep up the good work there, and I'll follow up with radiology just to kind of clarify the last question, because I think that's a good point. That's about it.
All right. Thank you, Tom. I'm going to try to make up a little bit of time. We're a little bit behind, but we need to talk about Beaker. So Beaker is going live. I think the lab shut down at 10 p.m. on July 15th. And then Beaker is supposed to be up and running by 4 a.m. on July 16th. Epic will stay up during this period of time. It's just that the labs will go down. So you'll need to be, I think, doing like paper labs. Honestly, we haven't gotten a ton of details about that yet. But Beaker is Epic's lab software, basically. And it's replacing our super old DOS-based system that was originated in 1992. It has a lot of new functionality. It also has a lot of safety precautions with, wrong specimens, lost specimens, other things to reduce the likelihood of lab errors and such. It's also capable of turning labs around faster and better with add-ons and such, but it is going to be a little bit of an adjustment for us. So let's talk about some of the more important aspects that will specifically affect us. This is one of the biggest ones. Everyone is going to realize this, and I'm honestly a little worried that this could potentially lead to errors, and not just errors, but errors that are undiscovered. Beaker is going to default to adding on labs to blood already in the lab. It will do this by default, and it will do this up to 3 days for blood that's already in the lab, and it will do this across encounters, which means if blood is already in the lab from an outpatient draw from 3 days ago, and you order a test that can be drawn on that tube that is already there, it will default, as you can see here at the bottom, to use existing specimen. Now, you can just change it to click it to new collection, which is what we should be doing like pretty much 100% of the time. But this is the default. We've asked to try to change this default for the emergency department and for certain lab tests. But be aware, this default will even apply to things like troponins. If you're ordering a second set of labs, let's say you've got a DKA patient and you're ordering a second BNP 2 hours into their study, if you don't click new collection, they'll just redo it on the same blood that they've already, well, that case is a bad example because it would notify you that it's a repeat blood draw, but it will try to do this. And unfortunately, when you save these labs as favorites, if you change the parameter to new collection, from what I've been told, it will not save that parameter, and it will go back to use specimen already in lab. So this is a really important one. There are certain expiration times for certain labs. So most labs, it will add it on if the specimen is up to 72 hours in the lab. The BNP, or the troponin and the CBC will add on up to 48 hours, and the D-dimer will add up to 24 hours. Don't ask me why they think that you can add on a troponin to lab that's been in the lab for 48 hours. So keep in mind that this also, when you run like a emergency medicine order set, and you just click all the default labs, let's say you do an order set like an ED abdominal pain order set, and it defaults to, like CBC, CMP, lipase, UA. If you just see all those clicks, all those checks, and you just hit OK, you may not realize that like the CMP is going to get run on old blood, but everything else is going to get run on new blood. And then when you see your results, they'll all result out as today's results because they were run today. And you could easily miss that one of those labs was from blood from 2 days ago. So it's a bit of an issue. Let me go back. This test that you see here where it says use existing specimen, the good news is if there is not an existing specimen, it won't default to this. So when you're ordering each test, you should see it will be marked as new collection, new collection, new collection, and then you get to another one and say use existing collection. That means that the system knows that there is blood in the lab, supposedly. The other big one is the rainbow draw. So as part of the safety protocols, per CMS regulations, you're not supposed to ever put two labels on the same blood tube. So you're not supposed to label on top of a label. What our current process is we use those PLUI labels, which is just the identifier, the patient identifier, and we stick them on the tubes and they go down to the lab, and then they print out the actual lab label in the lab, and then they stick it on top of the PLUI label, and off they go. We can't do that anymore, and so the nurses are going to be printing out all the wows that you see. They all have these little portable ticker tape printers now, and so what they have to do is they have to have the order for the lab. They have to use the laser scanner to scan the barcode on the patient's wrist. It sees that labs have been ordered. It ticker tape prints out the lab stickers at the bedside. They draw the blood based on what those stickers say, because they'll say, I need a blue tube, I need a, gold tube, I need a red tube. So they'll draw those bloods, and then they'll label them, and then they'll get sent down. If you want them to draw tubes that you haven't ordered yet, as in a rainbow draw, there is an order for that, and you have to actually order a rainbow draw, or they can order it themselves based on several of the ATP, or Advanced Triage Protocol, order sets that are in the system. So you can see here that some of these order sets will have a rainbow draw and some of them won't. And they're not supposed to practice outside of their license. So, if their presenting complaint is not consistent with one of the order sets that has a rainbow draw eligible for it, they won't be able to just order a rainbow draw using ATP protocol. They can still do it if they ask if they can, and then they have to put it in as a verbal order, and then you have to sign it. So this is going to take some getting used to, and we're going to be working closely with nursing to try to, ensure that we're drawing a full set of tubes when necessary, and using the rainbow draw blood order. Other random changes with Beaker, blood products, including massive transfusion, cannot be released without an actual order in Epic. So during those resuscitations, we're going to have to either go to the computer and order the massive transfusion, or a couple units of blood, or nurses or somebody is going to have to do that as a verbal order, but they will not release the blood based on a verbal order, or walking down with the paper. So get used to that. Critical results, life-threatening results apparently are going to require a provider acknowledgement. Now they do that already. They typically call on the phone. I'm not sure if that is, they didn't specify whether that can be done through Epic or whether it's going to be standard with a phone call. This I already went over. Tubes must be labeled at the bedside based on printed orders. One nice feature of this is when you're ordering blood, you can get into the details of that order and specify that a different provider should be notified of the result. So we're going to have to see how this really works, because some providers, if you specify a provider that doesn't use Epic or such, you may have problems, but this potentially could be a good way of forwarding results to other providers that are not going to return during the emergency department visit. Like if, you're doing some crazy workup and you need some send out lab that you're really expecting the PCP to follow up with. So that's a good thing. Here's another kind of big one. There's a bunch of orders. You know how there's like the syntax of the order, and then there's the lab number. Like with the COVID-19 test, you've got the SARS COVID-19, and then you've got like, lab 7888 or 7885 or 7901. Those lab numbers are going to change for a number of tests, mostly microbiology tests. But as a result of that, those tests that we're changing from are going to drop off of your favorites, drop off of your order panels, drop off of your customized order sets. And you'll have to add them back on with the new order, but you can't do it until after July 16th when those orders become available. So I'm going to send out with this kind of a summary of just these changes. This is a small list of the old legacy lab names and the new lab names. So, you're going to have to change, for instance, lab 6916 to lab 6915 if you want, a culture body fluid with gram stain. It's the same test, but it's different. Many of the microbiology tests were specific in our current version of Epic, and many of them are consolidated to the same lab order with Beaker. And what they're expecting is for you to change the parameters within the order. So it might be, culture body fluid with gram stain, and then you specify peritoneal fluid, and you can save that as a favorite, and then specify pleural fluid, and then specify, arthrocentesis, something like that. And we're just going to have to kind of play with this once it comes, but be prepared that, some of these labs are going to drop off of your favorites and need to be re-added. There's a whole job aid on this that's multiple pages. I sent it out last week with the provider updates. I may send it out again next week, but you're going to want to spend a little bit of time with that as we get closer to Beaker go live. Questions on Beaker? Just like with the troponin, please, once we do go live, I want you guys' feedback on this, so that, we can coordinate. Some of this will be education and coordinating with nursing staff, and some of it will be feedback back to the system for requested changes for workflow and safety. Okay, just very briefly on patient experience, our numbers have actually been improving some. ER 74.8%, so great job. Keep up the good work. We've got a little bit of a downtrend compared to the month prior. This is May. I don't have June's in here yet. But in general, we've seen some improvement. Keep working hard on this. This is for Southwest. The numbers obviously are much, much higher, so that's great. The last thing that I would remind people is, as of July 1st, at the beginning of this month, we have changed from Press Ganey to Qualtrics. And I did send that out in the provider updates as to the new questions. It's fewer questions. Some of them are going to be standard all the time, and then there's going to be a rotating batch of additional questions that kind of randomly, like you might get these 5 extra questions and someone else might get these other 5 questions. They do that to keep the survey manageable in terms of size, but to still get a wide array of questions. It's email, it's text message, it's supposed to be, we expect that the results will come back in more close to real time. There's some good tools that, the leadership, including myself, will be learning as we get new reports and such. So we're hoping that this is a good thing and gives us better data. All right, that's the end of the formal presentation stuff. There will be some additional stuff to review. So please flip through the slides as well as the meeting minutes when they come out. There will be some additional content in there not presented, and some reminders of relevant practice-changing stuff that's previously been presented as well. With that being said, open the floor to anyone for any additional discussion, anything to bring up, concerns, suggestions. All right, I'll give one plug. Molly is hosting a GREMG kind of social event, post-pandemic debrief. Really want to try to encourage everyone that's able to attend that. I think that is on the 19th in the evening, 5 or 6 o'clock. You've been getting notices about that in the provider updates. So we're really hoping that we can get a good turnout for that. And I think it's going to be a great event. We're hoping to do hopefully that's the first of several social events where we can get the team together and in a more social setting now that some of the pandemic issues are less a little bit less relevant. So. All right, with that, we'll sign off. Have a great day, and we'll see you soon.